Hello, everyone, and welcome to our module on thyroid anatomy and physiology. Let's start by talking about the anatomy of the thyroid gland. So as you may know, the thyroid gland is an endocrine gland. It produces thyroid hormone, which we'll talk about later, and it's located in the front of the neck, just in front of the trachea, and it's roughly the size of the palm of your hand. The thyroid gland is made up of two lobes, a left and a right, and that's what's shown in this picture here. This is one of the lobes, and this is the other one here. And the two lobes are connected by a thin band of tissue called the thyroid isthmus. And then sometimes there's a smaller lobe up here on top of the isthmus, and when that's present, that's called a pyramidal lobe. Blood supply to the top part of the thyroid gland is via the superior thyroid artery. This is easy to remember because it has the word thyroid in its name. And then the blood supply to the lower portion of the gland is via the inferior thyroid artery, also easy to remember. Now, the superior thyroid artery shown here is the first branch of the external carotid artery in the neck, and the inferior thyroid artery shown here is a branch of the thyrocervical trunk, which comes off the subclavian artery. Thyrocervical trunk has the word thyroid in its name, so that makes it easier to remember that it gives off the inferior thyroid artery. Okay, let's talk about the embryology or the development of the thyroid gland in utero. So you should know that the thyroid gland forms from the floor of the pharynx. So epithelial cells in the pharynx, meaning the primitive mouth, dive down into the neck. That's what's shown in this picture here. You can see these cells diving downward, and those cells are going to form the thyroid gland down lower in the neck beneath the floor of the mouth. Now, initially in utero, when the gland is forming, like what's shown in this picture here, a connection remains to the tongue. That's what's shown right here, and this is called the thyroglossal duct. This will disappear later in development. And in the normal adult, there are two remnants of the thyroglossal duct that you can find. One is the foramen cecum in the tongue. I'll show you a picture of this in a minute. And the other is that pyramidal lobe of the thyroid I talked about earlier. When that is found in a person's thyroid, that's a remnant of the thyroglossal duct. And so here's a drawing of the mouth and the tongue. And back here in the back of the mouth, at the base of the tongue, you can find an indentation called the foramen cecum. And that indentation is a remnant of the thyroglossal duct. That's where those epithelial cells in utero dove down into the neck to go on to form the thyroid gland. Sometimes a persistent remnant of the thyroglossal duct will remain in a person and go on to form a cyst. And this is called, as you can imagine, a thyroglossal duct cyst. It presents as a midline neck mass that is typically painless. This is a picture of what one can look like here, and it's usually detected in childhood. Now, the differential diagnosis for a neck mass in a child is huge and not something you need to know for step one. But what you want to remember about these thyroglossal duct cysts for step one is that classically they will move upward with swallowing or tongue protrusion. And this is because, like I talked about before, the thyroid gland forms from cells in the tongue, and so a connection remains in many cases of these thyroglossal duct cysts. And for that reason, when the child swallows or protrudes their tongue, it'll make the neck mass move up or down, and that's one of the hints that the child has a thyroglossal duct cyst. In addition, you can know that sometimes these cysts contain thyroid cells, and so if they're surgically excised and you look under the microscope, you will often see tissue that resembles the thyroid gland. Besides a thyroglossal duct cyst, the other sort of embryologic thyroid condition you should be familiar with is the presence of ectopic thyroid tissue. This refers to functioning thyroid tissue, so tissue that can produce thyroid hormone, but it's found outside of the normal location of the gland in the neck. And the most common location for ectopic thyroid tissue is at the base of the tongue. And this should make sense to you after what we've just talked about. So cells at the base of the tongue, the base of the pharynx, normally dive into the neck to form the thyroid gland. Sometimes some of those cells remain behind in the tongue, and they can become functioning thyroid tissue, and that's an ectopic thyroid. This can present as a mass in the tongue, so a person will present to their doctor complaining of a mass in the tongue. Often this occurs during periods of increased demand for thyroid hormone. So for example, children going through puberty or women who are pregnant, they need more functioning thyroid hormone, and so the glandular tissue will get stimulated, and that can make the mass larger, and that's when patients can come to their doctor and say, I have a mass at the base of my tongue. In some cases, the ectopic thyroid tissue in the tongue is the only functioning thyroid tissue in the body. When this happens, that amount of tissue is usually too small to produce enough thyroid hormone for the whole body, so it will underproduce thyroid hormone, and basically the person becomes hypothyroid. They don't have enough thyroid hormone in their body. This causes the pituitary gland to release more TSH, which stimulates growth of the ectopic tissue and just makes the mass bigger and bigger and bigger. So the way this will be described in a board question would be a person with symptoms of hypothyroidism and they have a mass at the tongue. That person probably has an ectopic thyroid, and that's their only functioning thyroid tissue in the body. Okay, let's talk about the normal thyroid gland histology. So if you were to biopsy a normal thyroid gland and look at the tissue under the microscope, you would see something that looks like my drawing shown here. What you have are cells surrounding these red collections of proteinaceous material. The proteinaceous material is called colloid. It's made up of protein. Most of the protein is thyroglobulin. I talk about thyroglobulin in another video, but it's a protein that's very important for the synthesis of thyroid hormone. So you have these collections of colloid, and they're surrounded by a single layer of cells, and those cells are called follicular cells. And these are the cells that make thyroid hormone. They can make T3 and T4, and I talk about the biochemical process of how this happens in another video. In addition to the follicular cells, you have these other cells, which are denoted in green here, called parafollicular cells. They make a hormone called calcitonin, and let's talk about that now. So calcitonin is a hormone produced by the thyroid gland. The thyroid gland doesn't just make thyroid hormone, it also makes calcitonin. And it's synthesized by those parafollicular cells we just talked about in the last slide. They're also called C cells. So if you look at this biopsy specimen from a normal thyroid, you have collections of colloid here, a single layer of follicular cells lining the colloid collections. And then out here, you have these other cells called parafollicular cells or C cells, and they're the ones that are going to make the hormone calcitonin. So what does calcitonin do? Well, it lowers serum calcium through a couple of different mechanisms. First of all, it can suppress bone resorption by inhibiting osteoclasts. It also inhibits the reabsorption of calcium and phosphorus from the kidneys, and it leads to more calcium going out in the urine. So through all these mechanisms, calcitonin can lower serum calcium. Now, it turns out that in humans, calcitonin has only a very minor role in regulating our calcium concentration. And that's because we have another hormone called parathyroid hormone, which I talk about in another video. And this is the major regulator of calcium. So calcitonin from parafollicular cells of the thyroid gland is not very important in humans for day-to-day maintenance of our serum calcium. It is, however, helpful in treating hypercalcemia. So calcitonin is sold as a drug, and it can be administered intravenously in large doses to patients who have hypercalcemia. And that's really the main place you'll see this hormone clinically is as a treatment for hypercalcemia. And I talk about hypercalcemia in other videos in the endocrine section and in the renal section. So for the next few slides, what I'm going to do is talk about the major effects of thyroid hormone in different tissue beds throughout the body. And I'll start by talking about the metabolic effects. So thyroid hormone is a major regulator of metabolic activity and growth in the human body. And basically what the hormone does is it increases the basal metabolic rate of the body. So what do I mean by this? This refers to the basal rate of energy use per time by the human body. Basically, it's the amount of energy you would burn or consume in your body if you slept all day. It's the amount of energy required just for the body to carry out its various organ functions, not to do anything extra like walking or running or jumping. And the way that thyroid hormone increases the basal metabolic rate is by increasing the number of sodium-potassium ATPase pumps found in the cells throughout the body. This is a drawing of what a sodium-potassium pump looks like. It's a pump found in the cell membrane of lots of cells in our bodies, and it brings sodium out of the cell and potassium into the cell. And these pumps are responsible for keeping the sodium and potassium concentrations inside cells normal, and they require ATP to work. So what thyroid hormone does is it causes cells to produce more of these pumps. And when there are more pumps, more ATP is consumed, and that's what raises the basal metabolic rate. In addition to more ATP being consumed, the body needs more oxygen to replenish ATP. So that happens when thyroid hormone exerts its effects. And because you need more oxygen, there's a higher respiratory rate when thyroid hormone is active, and this can raise the body temperature. And so if you know that thyroid hormone does all these things, it's an easy way to understand that patients who have hyperthyroidism, which I talk about in another video, they often experience weight loss. They can also experience increased body temperature and increased respiratory rate. And these are all features of excess thyroid hormone doing what it's normally supposed to do, just at an excess level. Thyroid hormone also has important effects on the heart. So just like thyroid hormone can raise the basal metabolic rate, it can also increase the cardiac output. It does this by raising the heart rate, the stroke volume, and the contractility. All of these things can increase in the presence of thyroid hormone. Thyroid hormone also increases the number of beta-1 receptors in the heart, and you may know these are the receptors stimulated by the sympathetic nervous system, and that's part of what makes the heart beat faster and more vigorously in the setting of thyroid hormone. And so if you know about these normal effects of thyroid hormone, then it's an easy way to understand that when patients are hyperthyroid, they're usually tachycardic, and that's because of these effects here. Some other things thyroid hormone does, it stimulates surfactant production in babies. So hypothyroidism in babies is very rare, but it can be very life-threatening because babies need thyroid hormone to make surfactant. Thyroid hormone is also important for regulating the menstrual cycle. So women who develop hypothyroidism, for example, often have irregular menstrual cycles. There are a number of biochemical effects that thyroid hormone has. It's very important for regulating glucose. For example, thyroid hormone increases carbohydrate metabolism. There will be more breakdown of glycogen, that's glycogenolysis. There's also more gluconeogenesis, and both of these things can increase the serum glucose. Thyroid hormone also promotes fat metabolism, so there's more lipolysis when thyroid hormone is around. It tends to lower the concentrations of cholesterol and triglycerides, and one of the ways it does this is by increasing the number of LDL receptors in the liver. And so when that happens, the liver pulls cholesterol and triglycerides from the bloodstream. Incidentally, this is the same way statins work. They increase the number of LDL receptors in the liver as well, and that's what helps them to lower cholesterol. That's how those drugs work. Also, thyroid hormone increases cholesterol secretion in the bile, another effect that lowers the serum cholesterol. So if you know about these sort of things and these things up here, it's easy to remember that patients who have an underactive thyroid, hypothyroid patients, they will get high cholesterol. And so in the differential for a patient with hypercholesterolemia is the fact that the patient could be hypothyroid. And in contrast, patients who are hyperthyroid have overactive thyroid gland, too much thyroid hormone. They often develop hyperglycemia, and that's because of all these effects right here. Thyroid hormone also has important effects on the central nervous system and in bones. So thyroid hormone is required for normal bone growth and central nervous system maturation in babies and children. So in another video, I talk about hypothyroidism in children, which is very rare, but when it does happen, those children tend to have short stature and underdeveloped central nervous systems. One of the ways it exerts this effect is through synergism with other hormones like growth hormone and IGF-1, which is another hormone that comes from the liver. And so by working synergistically with these, that's how thyroid hormone is responsible for bone growth and CNS maturation in babies and children. Now, in adults, excess thyroid hormone will stimulate bone resorption. So when adults develop chronic hyperthyroidism, they tend to develop osteoporosis. And that's because in this case, the thyroid hormone in an adult is not functioning towards bone growth, but it's breaking down bone, and that's what causes osteoporosis. So the level of thyroid hormone that's found in the blood is maintained within a narrow range. So let's talk about how those levels are regulated. So it begins in the hypothalamus, which can release a substance called TRH, or thyrotropin releasing hormone. This stimulates the anterior pituitary gland to release another hormone called TSH, or thyroid stimulating hormone. TSH then goes and binds to receptors found in the thyroid gland, and that triggers the thyroid gland to produce T3 and T4. And then the serum levels of T3 and T4 feed back on the pituitary gland and also on the hypothalamus. So when the T3 and T4 levels get high, they tell the hypothalamus to release less TRH and the pituitary to release less TSH. When the levels of T3 and T4 get low, this inhibition is removed and more TRH and more TSH will be released. Now, just to provide a little more detail on how this process works, the TSH, which is released by the anterior pituitary gland, binds to receptors on follicular cells. We saw those cells earlier. They're the cells that surround those colloid follicles inside the thyroid gland. And when TSH binds to those cells, it activates a second messenger system that functions through cyclic AMP and protein kinase A. And I talk about this type of second messenger system in another video. But the point here is that the TSH coming from the anterior pituitary gland binds to follicular cells, activates this second messenger system, and that leads to the release of more T3 and T4 from the thyroid gland. The way this happens is there's more proteolysis of thyroglobulin, and this leads to rapid release of more T3 and T4. I explain how thyroglobulin works in another video, but basically it's a big protein with lots of T3 and T4 molecules attached to it. And so when TSH binds to follicular cells, it basically lops off all these T3, T4 molecules, and they go out into the bloodstream, and that's what raises the amount of free T3 and T4. In addition to TSH stimulating the thyroid gland to produce T4 and T3, it also stimulates growth of cells like follicular cells. It also stimulates the production of thyroid globulin. And so by doing all of these things, this leads to more T4 and T3 production. And that's how TSH works in the thyroid to produce more thyroid hormone for the body. And that concludes our module on thyroid anatomy and physiology.